join me in welcoming Dr. Reddy.
Thank you all for having me here today. So as mentioned, I'm a breast medical oncologist. And in addition to treating patients with breast cancer in my clinic, I also help in the design of clinical trials looking at improving the outcome of my breast cancer patients with a focus on immunotherapy, which I'll be talking about today. So cancer, okay. So as physicians and as scientists, we tend to focus on the cancer cell itself when we're thinking of how cancer forms. When the normal process of cell divisions, when one cell divides to become two cells, sort of goes awry, and we get some mutations and abnormalities, that's when we think of forming cancer cells. Over the series of many divisions, one cell becomes a million, and at each step of the way, each round of cell division, we can get these genetic abnormalities that give these cancer cells additional capabilities to do things such as invade past their original surroundings, such as the breast, and further metastasize and spread through the blood vessels or lymphatic vessels to more distant parts of our body. And shown here are common places that breast cancer tends to metastasize to. When we think of cancer, we often think of chemotherapy. So chemotherapy is one of the earliest systemic forms of therapy that travels throughout our body. As I explained on the earlier side, many of these cancer cells develop these capabilities of being able to invade and metastasize to more distant parts of our body. So even with the best of our screening modalities, such as mammograms and other imaging techniques, oftentimes these cancer cells have already developed these capabilities to spreading outside of the breast by the time they're even diagnosed. In some patients, this is unfortunately a stage 4 or metastatic breast cancer, when we say it's clinically significant and we can actually detect them and they're causing symptoms. In other cases, it's microscopic disease in which we have cells or clusters of these cancer cells that have deposited elsewhere in the body and might not have figured out quite yet how to set up shop and grow in that area. For this reason, the treatments we give to our breast cancer patients are not just surgery or radiation therapy to address what we see in the breast, but also systemic therapy that can travel throughout the body with the goal of trying to kill those cancer cells that may have already escaped from the breast before they can set up shop again and grow and cause a problem. So chemotherapy is one of the earliest types of systemic therapies that we use in the treatment of cancers, including breast cancer. It works by non-specifically killing any cells that are growing quickly, which oftentimes are cancer cells, but several of our normal cells also grow quickly, such as hair, those related to fingernails, the cells lining our gastrointestinal tracts, and this is associated with a lot of the side effects we commonly think of when we hear of chemotherapy. Over the last few decades, our research has advanced tremendously, and we now are more aware of the specific molecular pathways within our cancer cells and the machinery that different cancer cells need to divide. So breast cancer especially has led the field in what's called targeted therapies, where we're focusing on the specific pathways that breast cancer cells are uniquely dependent on that maybe the normal cells in our body are not dependent on. So with developments such as endocrine or anti-hormone therapies that can interfere with breast cancer's dependence on our estrogen, with anti-HER2 therapies that are relevant in about 15% of breast cancers that depend on this pathway, and other pathways, we've seen significant improvements in the survival of our breast cancer patients. But despite this, there's still several areas of unmet need. First, in patients that have stage 4 metastatic disease, despite our chemotherapies and targeted therapies, unfortunately these patients often pass away from their disease because these treatments only work for limited periods of time. In our localized or earlier stage breast cancer patients, again, the majority of them were able to cure and prevent this cancer from coming back, but there are still some where that microscopic disease is hiding somewhere in the body and figures out, despite getting chemotherapy and our targeted therapies, how to come back and grow and become stage 4 metastatic disease, which again is a very difficult entity to treat. We now know that our breast cancer is not just clumps of cancer cells that might be rapidly growing, but it's a more complicated ecosystem that consists of other cells such as immune cells surrounding it. Of course, the breast cancer cells form from genetic abnormalities, your environment, just chance that can lead to the formation of these abnormal cancer cells. But again, there's several immune cells and others such as blood vessels that interact with it really from day one. And as mentioned with the last talk, there's many years that sort of lead up to this before the development of a clinically significant cancer itself. So over the course of our lifetimes, our immune cells are detecting our cancer cells as foreign, and much the same way that we think of them attacking an infection, they attack our cancer cells and eliminate them before they ever become a problem for us. And shown here is sort of in real time, a video, and if you see the large cells, those are the cancer cells, and these smaller circular cells are the T killer cells or our immune cells that are latching on to the tumor cells that it's recognizing as foreign and starting to attack it, or sort of here it looks like it's eating away at it. And eventually the cancer cell sustains enough damage that it undergoes cell death, which is labeled here as apoptosis, and it's able to get rid of the cancer cell in that way. And shown here is a sort of artificially colored image of this, where you see the T cells attacking the cancer cell in the middle. Now, again, every time these cells divide, they're able to acquire additional abilities and abnormalities. So while the immune system is able to eliminate the cancer cells it's able to detect as foreign, you get some cancer cells that are able to figure out how to hide from the immune system. And you ultimately have standoff between the cancer cells and the immune cells. And eventually, some of these tumor cells and tumors can figure out how to completely escape from the control of the immune system, and that's when we get these clinically significant tumors that we detect in our patients. So immunotherapy, which is the focus of my talk today, is a type of cancer therapy that's focusing on enhancing the elimination of cancer cells by our immune system and preventing this escape from immune control that we see when our patients develop breast cancer and other cancers. So cancer immunotherapy, and more specifically immune checkpoint blockade, which I'll be talking about today, has really been a breakthrough in cancer care in the last decade or so, with Science magazine calling this breakthrough of the year in 2013. So shown here is an immune checkpoint. So normally we have our T cells shown in purple that recognize an antigen or something on the tumor cell that's detected as foreign, where it can sort of bind to this and then initiate tumor cell killing. In our body, we have a system of checks and balances because we don't want our immune system to become hyperactivated. Unfortunately, our tumor cells can hijack the system and develop and express these proteins, such as PD-L1 here, which is an immune checkpoint, that essentially puts a brake on the system and prevents the T cell from doing its job. So immune checkpoint blockade therapy blocks this immune checkpoint and thereby releases the brake on the immune system, so the T cells that are already in the tumor can go about doing their job and moving ahead and killing the cancer. So shown here in the schematic is what's exciting about this group of therapies. So in those with stage 4 metastatic disease, and this is not specific to breast cancer, but chemotherapy, targeted therapies, they may work for some period of time, but eventually they stop working. And shown here on the y-axis are patients that eventually are alive without progression of disease. But what was very exciting about the initial immunotherapy trials is you see this very flat survival curve, meaning the patients that respond, a subset of those continue to respond for a prolonged period of time, such that we're able to take these patients with incurable disease, and some of them are living for years, so I can say we're moving closer to them potentially having incurable disease. And beyond these initial immune checkpoint blockade agents, we've seen improved response rates and more patients that are responding with PD-1, PD-L1 immune checkpoint blockade, like combining these different types of immune checkpoint blockade, and there's active research into seeing how can we get more and more patients to respond to this. In breast cancer specifically, we've also seen some initial exciting results from our preliminary studies. Shown here is a spider plot from one of the first immune checkpoint blockade trials that was shown in breast cancer. So as you see here, and here each line represents an individual patient, and along this axis is whether they had a growth in the size of the cancer or a decrease in the size of the cancer. In this specific clinical trial, patients had metastatic triple-negative breast cancer, which is a particularly aggressive form of breast cancer. And also these patients had received several lines of chemotherapy that did not sufficiently control their tumor prior to enrolling on this trial. So it was particularly exciting to see several patients with this aggressive type of cancer have disease responses, including one patient that had previously progressed on 8 different lines of therapy, have complete control of disease with this treatment. Shown here is a case report from a patient that got something called adoptive T-cell therapy. So with adoptive T-cell therapy, you you surgically cut out part of the patient's tumor, and you then extract the T cells or the lymphocytes from the tumor and start growing them in the lab. At the same time, you take their tumor and it goes through genomic sequencing and some computer algorithms to basically tell you what part of this cancer is something the immune system can actually recognize as foreign and try to use to kill off. Then you take the T cells or lymphocytes that you were growing in the lab and check for what actually reacts against what you're predicting in the cancer that it can react to. You sort of pick your winner population of these are our lymphocytes that are most likely to be effective, further grow them out in the lab, and then infuse them back into the patient, in this specific case, with these immune checkpoint blockade agents. And what was remarkable was after this limited period of treatment, this patient sort of had complete control of disease afterwards and has not required additional cancer treatments after that. And this was a patient with stage 4 metastatic disease that again had progressed through several lines of treatment. But other than a couple of case reports showing this and the initial trials showing responses in a few patients, unfortunately the majority of breast cancer patients do not seem to benefit from the current therapies we have focusing on the immune environment. In larger trials where we can more accurately assess what the response rates are, we're seeing that some respond, but the vast majority do not. We recently also heard from a large phase 3 clinical trial in which giving an immunotherapy compared to the standard of care chemotherapy did not lead to patients on average living any longer than if you just continue with the chemotherapy. What we have learned from the many clinical trials we've done thus far, though, is it's the patients who actually are positive for a biomarker called PD-L1. And on the prior slide, actually, the patients on that triple-negative breast cancer trial, they were all required to be PD-L1 positive when they enrolled in the trial. These tend to more likely be the patients that benefit. So PD-L1 is the specific target that these PD-L1 blockade agents are testing against or trying to sort of counteract. That makes sense. But also, this means that there's already a pre-existing immune response in the tumor. So these are tumors where the immune cells have already figured out how to get in the tumor, and they just need some help kind of with the final steps of the job. To really understand how to expand these immunotherapies to a greater number of our breast cancer patients, we need to understand the different steps that are required to generate that anti-tumor immune response. So first, you need something on the tumor, first of all, that's able to be detected as foreign that the immune system can recognize. Then these antigens, that we call them, need to be released into the area around it so that it can be picked up by an immune cell. We have these special antigen presentation cells that have to pick up these antigens. Then they travel to and find these killer T cells and basically show them the antigen and tell them this is foreign and we're going to prime and activate you so you can go in for the kill. The T cells then need to go back into the tumors and survive in what the tumor has made a pretty hostile environment. They then have to find the cancer, find the antigen on it, and then they can go about killing. So there's a few things that are needed for this to happen. Now, this PD-L1 immune checkpoint blockade acts on this final step. So it's the tumors where all these other steps are intact that this current class of immunotherapy that we're using is able to take effect. Now, if we go back to this first step again, the cancer cell has to have something foreign to start with. So unlike viruses and bacteria and things we're commonly thinking of with our immune system, our cancer cell forms from self cells. So it's harder for the immune cell to detect what's not, what's a slightly abnormal version of self from self. But the more mutations you have, the more chronic exposures such as UV light and things that develop over the course of the life of this cancer cell, the more likely it's going to express something that's foreign that will be picked up by the immune system. And in fact, this is what we're seeing clinically. So you see here, and on this graph, it's showing the more mutations a cancer has, and this is showing for each type of cancer, the greater the response we're seeing with these immune checkpoint blockade agents. And you see where breast lies on this curve. It's on the lower end of both of these, whereas melanoma you see on the higher part of this. But what several groups are doing is saying, okay, well within, even if breast might be a little bit lower or whatever the tumor type is, what if we select the patients that actually have higher mutations? So this is a clinical trial in lung cancer, for example, where they took patients that had higher than a cutoff of 10 mutations per megabase and said, well, let's treat them with a combination of these immunotherapies and see how they do. And shown on the survival curve, where the higher curve means the higher number of patients that are surviving, the patients that got immunotherapy did a lot better in terms of survival than those that just got chemotherapy alone. We're studying this at UT Southwestern to see if the similar principle holds true in breast cancer. So in this Nimbus clinical trial, we're going to take 5 to 8% of patients that have this high mutational burden cut off of 10 as used in the lung cancer trial and treat with the identical regimen to see if we get favorable responses. This study recently opened in the last month, and we're excited to see what the results show. Now again, if we go back to this first step, what if these tumor cells need a little bit of help in expressing these antigens so it's easier for the immune cells to pick them up? There's a lot of investigation at UT Southwestern and elsewhere where we're trying to see if we can facilitate this process by killing the cancer cells so they actually release these abnormal antigens and the immune cells don't have to work as hard for it. And in fact, in breast cancer, we've actually seen much more success when we've combined chemotherapy with immunotherapy rather than give immunotherapy alone. So in this clinical trial, we basically either gave chemotherapy by itself or chemotherapy plus immunotherapy. And what we found was that the overall survival of patients who tested PD-L1 positive, so again, already had some pre-existing immune response, and received the immunotherapy was significantly improved from 15 months average survival from diagnosis of stage 4 disease to 25 months when immunotherapy was added on, which is a significant improvement and I think a good place for us to start. We recently heard earlier just this month that adding these to earlier stage disease when the disease is just in the breast may also decrease the likelihood of this cancer coming back. But still, there's much work to be done. We need to see how to expand this to even more breast cancer patients and how we can really try to make this a survival tail where we can get these patients continuing to respond and potentially moving closer to cures. And again, with limited number of patients responding, we need to better see how can we pair the right patient with the right tumor. So I think it's an exciting time in cancer immunotherapy research and for patients right now because we have, as you see here, many different drugs, again, different steps of this pathway that we can be using to see, well, how do we get this to actually work in breast cancer patients? But one issue I think we're running into is we just have too many drugs almost that we can feasibly test in patients. So shown here is the increase in the drugs that are being developed that are immunotherapies from 2017 to 2019, with each circle kind of representing based on the size and the number inside, the number of drugs being developed by pharmaceutical companies against a specific immunotherapy target. So you can imagine, we cannot test all of these to see which is the right one in breast cancer patients, and the number of possible combinations with chemotherapies and other therapies is limitless. So it's particularly important that we have intelligent clinical trial design and also translational research. So what do I mean by translational research? I think in addition to studying survival and other clinical endpoints, we need to look in the patient tissues. So ideally, we should be looking up front in a patient that hasn't been treated to see what's even in the breast cancer tissue. So what are the different immune cells that are there? How are they interacting with each other? What are the right immune and cancer targets we should be using so we can better say, okay, these are the drugs that make sense in this patient. Then we should look at them after they've gotten treatment to see, well, how does that change with the treatment? Because we know from mice and other models what's happening in the lab, but what's happening in real female patients that are undergoing this. And then I think the last important part of this is how is that different between those that are responding to therapy and those that are not. In those that are responding, what is it about them that help them respond that we can use to decide who are the patients we should be treating? And in those that are not responding, what can we learn so we know what is the right thing that we should be treating them with in sort of the next generation of clinical trials? And with technology that's advancing, we are better able to look inside the tumor, and shown here with each color represents a different type of immune cell. So we can look inside and actually see what is there, how are these immune cells organizing in sort of fighting against the tumor. And the last thing I wanted to point out is that now we're learning beyond just what's in the tumor cells and maybe even the immune cells around the tumor cells. We need to look at the whole picture, so the host, so what's happening with the patient, what's happening with their external environment and lifestyle factors. So there's a lot of research now showing the microbiome. So the bacteria that are in your gut can directly affect your response to immunotherapy. Closely linked to that, your diet. So high fiber diets are associated with better responses to immunotherapy, whereas antibiotics and even probiotics can negatively affect your microbiome to decrease your responses to immunotherapy. And there's a lot of research looking into other lifestyle aspects as well. So I think the take home is we need to really look at the full picture together, not just what we as doctors can prescribe, but how can we incorporate that with everything else in the patient to kind of have a more comprehensive treatment approach. So with that, I want to conclude and say, I think we're just scratching the surface here on how we can use immunotherapy to improve breast cancer outcomes. There's a lot of future promise with an increase in clinical trials that we're offering at UT Southwestern and at other sites in the country, so we can better provide the best possible treatments to our patients and see which of these agents may be best to generalize to everyone. There's an increasing understanding with that translational research of what's happening in the actual tumor and how could we use that to guide the best treatments. And then again, a greater appreciation, how could we sort of incorporate the whole person in leading to the best outcomes. Ultimately, I think in the future, this will lead to a personalized care where we can look at a patient's tumor. And we're doing this largely with molecularly targeted therapies, but also incorporate immunotherapy into this, so we can say these are the right patients for the right, or the right treatments for the right patient based on what we're seeing in their specific tumor. So with that,
Just
thank you all very much.
fantastic and fascinating. I'm sure we have some questions, so who's going to be first? Yeah, go ahead.
Could you speak to the vaccines and how you've seen them work for breast cancer using their tumors, specifically to release the antigens?
Yeah, so it's an area of active research. We haven't yet seen the sort of home run yet. So initial vaccines, we're trying to identify, well, here's a specific target we've pre-identified in patients, and let's try to give those. So HER2, for example, we see commonly in 15% of breast cancer. So there's been a lot of vaccination attempts in patients already diagnosed with that type of breast cancer. One thing we've learned from vaccines is they work best when there's less disease overall. So once you have a lot of metastatic breast cancer, it's very difficult to get vaccine to sort of, get your immune system activated to the point of controlling all of that disease. But in patients, who, let's say, has localized disease, it was taken out by surgery, they got chemo, then giving a vaccine, trying to get rid of the microscopic disease, that's where we've seen a little bit more effect. Now there's a lot more, there's many companies as well as labs looking at, taking a patient's tumor and creating a personalized vaccine against them. So a lot of investigation in clinical trials. Again, we haven't seen, those outcomes yet where it sort of made it to clinical care. And I think one area of interest area of research that I think is really cool is using radiation as sort of an auto vaccine. Because if you give radiation to a site, let's say in a patient who has multiple sites for their metastatic cancer, that in itself releases some of those antigens locally, so you don't have to physically take it out and make a vaccine. You can kind of make a vaccine in the patient by radiating one spot, give it with this immune checkpoint blockade or other immunotherapy agents to then kind of come in and sort of put additional force behind that auto vaccine that you're generating. But again, I think it's in a few years we'll know more of how to get it to work, even though conceptually it makes sense that it should work.
You mentioned that in some of our patients with breast cancer, we will actually take part of the breast cancer tumor itself and sequence that in order to better tailor the therapy going forward. What percentage would you say we're doing that now, and do you ever see a point in time in which everyone will get that tumor sequencing?
So right now, UT Southwestern, we're trying to do it for almost all of our metastatic breast cancer patients. And we're able to link it to sort of the clinical benefit to the patient, because we have a lot of, right now, targeted clinical trials. So some of it with targeted therapy, some of it with immunotherapy, where based on what we see, what mutation there is, or the number of mutations, if it's greater than that 10, what is the best sort of clinical option to treat you with? And especially in metastatic breast cancer, I think it's always good to see what's your standard of care, FDA approved, option, but what is the clinical trial, and is that better than what sort of the standard of care is? So I think the standard of care in metastatic breast cancer really should be to sequence, again, if you can pair it with clinical options. I think with time, that'll move towards even localized breast cancer, because one, we do actually use a lot of genomic sequencing in patients, let's say, with localized hormone receptor positive disease to decide, do you need chemo or do you not need chemo? Or are you someone that would only have side effects but not benefit from the clinical benefit of chemo? And I think with time, we're going to start to use that in all cancer patients, really. It's just as long as the treatments catch up to it.
You had a comment, Dr. Artiao?
Yes, I do. So these therapies seem to be smarter than chemo. So can you comment on the side effects, the toxicities, and how do they pair up? with the toxicity of chemotherapy?
So yeah, so I think different toxicity profile. They seem to be better tolerated in a day-to-day setting. You know, we're not necessarily having a significant of nausea and the things we traditionally think of with chemo. But the types of side effects you get with this is it activates your immune system against the tumor. So it similarly activates your immune system against everything else. You know, ideally it shouldn't, but when it's not perfectly specific to the tumor, it can. So then that's where we can see some rashes. We can see colitis where you have inflammation of your colon. You know, so we always tell patients on these therapies, if you're having diarrhea, let us know, you know, how bad it is. Is it something we need to shut down the immune system by giving steroids or something else to kind of undo the hyperactivation we might be doing somewhere else? So I think we need to be very careful as we're testing these, and so the ones, you know, that have not been approved, where we do not have as much experience on, it's very important to be tested in the context of a clinical trial, and at centers, even just what's FDA approved, where people are used to not only treating with this from a clinical benefit standpoint, but seeing the toxicities, and you have that specialized team to help you address whatever issues may came up while you're treating. And then now that we're doing so many different combination therapy regimens, then I think, again, trying to see, well, how do these toxicities sort of add to each other? How do you sequence things? So we learned, you know, I think in lung cancer, if you treat with immunotherapy, which is now standard of care after you get chemotherapy and radiation to localize lung cancer, but then you treat with a targeted therapy after that, they have much higher toxicity, which we would not have known until we saw it, compared to if you did it the other way around. You know, so just the biology is interesting. That's also affecting the different toxicities we see.
Yeah.
This question is for you, and actually Dr. Arteaga too. Has there been any consideration in, as we do with babies, saving umbilical cord bank, saving tumor banks because of the advancements in treatment further down the line? You might have more knowledge about a tumor than you would have. Is there anything like that? Would that work? Is that possible?
Yeah, I mean, I think, so one, just part of clinical care, if we do any biopsy, take any tissue, UT Southwestern, let's say, I'm sure each center has its slightly different specifics, we keep it for like 10 years. So no one's getting rid of it, you know, just because your procedure's done or you're not even a patient there anymore.
So it's already kept?
It's already kept. You know, they may not keep, if they do a mastectomy, all your normal breast, but the tumor tissue is kept for a certain number of years at each institution. So that's helpful if you then have the cancer come back. Then we can pull that, and we commonly do this, or if a patient comes to us from elsewhere, we'll commonly reach out to wherever they had their first biopsy done and pull that tissue and say, well, now we're gonna test for this PD-L1 protein to see if you qualify for this drug that's approved, or now we're gonna sequence this to see if you qualify for one of our clinical trials. So not everything has to be a fresh biopsy you get every time you need it. And then we're also linking into it at academic centers where we're using that to learn from, well, we have these thousands of women that have, you know, we have wonderful tissue from to learn from, so we can develop this new, you know, wave of treatments, you know, again, not interfering with what's needed from a clinical standpoint for that patient, but if there's excess tissue. So there's tissue banks, but I think we need more organization with time. And I think sort of as the world is just becoming more connected and social media and, you know, better marketing, I think even out in the community, there's different efforts to allow patients to contribute their tissue to banks with, you know, rare breast cancers or metastatic brain mets, whatever, to answer some of these questions. But from a clinical standpoint, people keep the samples so that the patient can benefit later on.